Well, first of all, thank you to the organizer and to all the esteemed participants. I am going to ask everybody to click on their seatbelts because I'm going to make a very quick shift in direction. I was asked to speak about the mental health perspective on traumatic events and post-trauma as one of the results of being exposed. And I will speak about post-traumatic stress disorder, or PTSD generally, but I will emphasize factors that are still relevant to the Rwandan experience. And as I hope to show that even though almost 26 years later, this is still very much a contemporary challenge, putting me in sync with the rest of my panel. Looking for illustrations for my presentation, I found 3 tiers in the cricket field, I believe it is, in Kigali. So I brought the presentation home. Next slide, please. Okay, next slide, please. The conceptual basis for the analysis I'm making comes from the world of public health. Some of you might know, I'll just review it very, very quickly. The 3 levels of prevention are talked about. Primary prevention, which is an attempt to prevent a disease or an injury from happening before it happens. Secondary prevention, which is mediating the possibility of people who were exposed from developing anything more serious. And tertiary prevention, which is improving the life once a situation has developed. Next slide. Putting this into the perspective of mental health, I'm going to talk about primary prevention as a universal intervention through the use of psychoeducation. That's the use of widespread education, public education, to basically everybody as a means of preventing things from developing. Secondary prevention would be a group interventions with people who have been exposed and are probably at risk of developing certain disorders or certain difficulties. And tertiary prevention, which is essentially treatment of those who have already expressed some sort of disorder. Okay, but next please. In a much more catchy way than I came up with it, the United States Substance Abuse and Mental Health Administration came up with, or this is part of a conceptualization that they made, speaking about realize, recognize, and respond. So if you want to remember anything, remember those 3, and it'll take us much further. Next. So the first tier is the realize, primary prevention, the community level psychoeducation of PTSD. Now, why would we want to do that? Okay, first of all, it's what we call in the business normalization, okay? Because one of the realities of people who are suffering from many mental difficulties, many anxiety disorders, depression, what have you, is that people suffer alone. They don't share what's going on. They think that they're crazy, and hence they suffer alone and don't reach out to get help. There's something wrong with me, I can't be fixed, okay? So the first thing that we can do is tell people, and I'm going to show some brief examples of the things that we can tell people, that after a traumatic event, there is this and this possibility of such symptoms, and all you have to do is first ask for help. And that's the most important thing that we can get out there, that there's nothing wrong with you, or as one of my mentors used to say, these are normal reactions to abnormal events. So taking away, and in doing so, reversing the isolation, the stigma, and the factor that more than anything else preserves the PTSD, which is avoidance. And I'll talk a bit more about that later. As in the event, it talks about the true nature of anxiety and the purpose that it serves, encourages interventions which may preempt some of the secondary problems caused by PTSD, which can be substance abuse, anger, aggression, violence, domestic or community. Okay, the development of guilt, depression, and other disorders. And possibly most importantly, it can engage the family of the one suffering to know how to respond more correctly, because sometimes we use our heart, but that's not completely in line with what psychology tells us. Next. So when I talk about sample psychoeducation for PTSD, this can be distributed in any way that we can get the message around, be it in the movie theaters, newspapers, speeches, public presentations, or as in the upper right, the use of school as a means to get education out there, which the kids can then take home, and the message gets around even further. All right, so I'm not going to go into a lot of detail about the timeline of PTSD. Relative to the Rwandan experience, most importantly, is the possibility of delayed onset PTSD, which can come anytime after 6 months, either because it was a delayed reaction or because a subsequent traumatic event brought out the expression of PTSD of an older event. So we know today that being exposed to trauma doesn't make you resilient. If, in fact, anything, it makes you weaker. It makes you more vulnerable. So a subsequent trauma, whether it's a car accident, can bring out a reaction to an earlier trauma. So that's why this timeline is relevant even to the Rwandan experience of almost 26 years ago. One of the things that I would get out there, or what does PTSD look like? And I'm not going to go through this entire slide, but the categories are, number one, that there was a traumatic event, and there's no question here. And then the psychological symptoms are around intrusive experiences, nightmares, flashbacks, things like that. Avoidances of anything that reminds you directly, indirectly, it makes sense, it's dangerous or not. Okay, I'll just give a quick example. People who are exposed to a car accident and there were bodies around the road, and they might not go to a barbecue because the smell reminded them of the smell of burning flesh. And that can be an avoidance which has nothing to do with danger, okay? But that's the level of avoidance I'm talking about. Changes in mood, cognition, and affect, emotions. The world is dangerous. I am incompetent because look at the way I've reacted, and I can't trust people. All right, those are the major three cognitive changes. And arousal hyperreactivity, basically startle reaction, jumping when other people don't react so strongly. So this is what PTSD is. It's very important to get the clinical picture out there so people can say, wow, this looks like what I'm experiencing or what my loved ones are experiencing. A quick view of trauma and PTSD by gender. The middle bar in each of the two groups is the percentage of people in the world to have developed PTSD. 60% of men on the left, or on your left, 60% of men, almost 61%, are exposed to a traumatic experience. Only 8 develop PTSD. The numbers for women are 51%, but 20% develop PTSD. Now, lest you think that points to a greater vulnerability amongst women, come to the next slide, we see that the type of trauma very much influences the development of PTSD. So, whereas accidents and assaults are more moderate rates, rape is by far and away the highest incident of the development of PTSD to people who have been assaulted. So that goes a long way to explaining why the percentage of women developing PTSD is higher, and that, of course, is extremely relevant to the Rwandan experience. Next, please. All right, some of the other correlates which are important to get out into the knowledge of the medical world, particularly primary health care. People with PTSD develop almost 3.5 times the rate of immune system disorders, almost 2.5, or more than 2.5 times muscular skeletal problems, on and on and on. So this is information that the medical community has to know in order to make connections where connections might be made. Okay, so again, this is some of the information I would get out there. Psychiatric comorbidity, people with PTSD as their primary diagnosis, okay, have a 70% likelihood of a comorbidity, in other words, having depression at the same time. All right, something to look out for, something to be aware of, and something to treat, whether together at the same time or, if necessary, as an adjunct treatment to the treatment of trauma. Very important on a societal level is more than a 30% incidence of alcohol abuse and dependence, and that doesn't mention illegal substances or medicines which are taken not according to the prescription. So that would raise that number quite significantly. Why do people do that? To escape the suffering caused by their symptoms. It's another example of the avoidance I talked about a minute ago. Okay, let's go on. Now, this is in response to mass trauma, okay, which certainly the Rwandan experience qualifies as. 65% roughly of the population might develop PTSD. All right, 37% might develop depression. And again, the nature of the trauma is going to very much influence the development of PTSD. On the other hand, the fact that it happened to a mass of people makes it more likely that people will communicate between themselves, amongst themselves, and that can set off and mediate the effects and possibly lower the possibility of developing PTSD. So it can work in both ways. Really scary but important statistic to get out there. 19% of current sufferers of PTSD will attempt a suicide act. Okay? We have to be aware of that. We have to know that. We have to alert people. And we have to look for the warning signs of suicide. Suicide begins with a thought, but doesn't automatically become a full act of what's called in the literature a successful act of suicide. Okay? A person has to go through many stages of having a thought, deciding how to do it, when to do it, have a plan. It's in the context of giving up hope. It's in a context of feeling alone. All right, one of the strongest predictors of suicide is the feeling of loneliness. So everything goes back to what I was saying about getting the information out there. There are treatments for this. People don't have to suffer alone. And by doing so, you're going to reduce the danger of suicidal behavior at the same time. Okay. This is very important for our current context, and I put the dates down at the bottom. This is a chart showing for various kinds of traumatic events that led to PTSD, the spontaneous recovery. Most people who develop some sort of traumatic reaction spontaneously recover. Without any formal intervention, their symptoms will subside. And you can see that the very steep decline on the left side of the graph. However, by about 5 years, there is going to be no more spontaneous recovery. And that's where the graph flattens out. So translating that to the Rwandan experience, if the original traumatic experience was 1994, by 2000, most of the people who were going to have spontaneously recovered did. And in 2020, the numbers are still being maintained. All right? So that's an important thing for us to realize, that even if we, 26 years later, there are plenty of people out there who need looking after, who need screening, and who need intervention. Okay? Because depending on which color of the line you're looking at, let's go for the middle, you could still be talking about some 20% of those who developed PTSD in 1994 will still be suffering today. So that certainly justifies investing in interventions today. Okay, so that's the kind of ideas that I would put out publicly. Now, I wouldn't put them out in slides like this and graphs and very academic looking. I would point you, if I had time, I would show them. I would point you to all sorts of animated clips that are out on the web that can be, I assume they can be used because they're on the web for public consumption. For example, the Veterans Administration in the United States have made a couple of really nice animations about PTSD to get the word out there, and about particular treatments which people can then go and ask to have. Now that's within one hospital administration, the Veterans Administration, of course relating to all Army veterans in the United States, but that's the way through an animated presentation that I would get this same information out there. I want to move to the second tier, recognize the people who might be at risk, that might be a danger, and I'm going to talk about very briefly, or mention really, 2 interventions that I think are promising. Okay, the first is an organization that I'm involved with, the Center for Mind-Body Medicine, which is in Washington, D.C. We have a local not-for-profit in Israel. The pictures are from some of the trainings that we've done around the world. Israel, Gaza, American forces and Israeli armed forces. On the bottom we have Kosovo, and on the bottom right, the work that we did in Haiti for the 5 years following the terrible earthquake in 80. Okay, so the philosophy of the intervention of Center for Mind-Body Medicine and the work that we do is that self-care is at the heart of all healing. And this is a man that I met in Haiti who for him, painting was his way to express what he was experiencing, what he was feeling, and the way he was processing. Next slide, please. To show you the concept is that we start by developing the ability of people to take care of themselves, giving them tools with which to do that. When necessary, we engage professionals to help people develop their own way to help themselves. In other words, the teaching is by professionals, the intervention is still people on themselves where possible. Because, like I say in my clinic every day, we can do wonders here in my clinic, but this 4-meter by 4-meter room is not your world. Your world is out there, and you have to be able to employ your healing in the world out there. Okay, and then when necessary, and only as the last level of intervention, we have traditional medicine of surgery, medicines, and all the other things. So nobody rejects anything here, but we're sort of ordering the pyramid to start with self-care. In one slide, this is pretty much the self-care tools that we teach in small groups. Everything from using music, guided imagery, meditation, movement, et cetera, et cetera, et cetera. Given the opportunity, I would love to expand on that. Okay. I'm just going to mention this. I'm going to ask you to skip forward. EMDR, some of you might know, eye movement desensitization for trauma. They have had some spin-off interventions which are done in groups for immediate response to traumatic events, and that's what I wanted to mention here. Let's go. I'll skip the video clip because we don't really have time. And I want to get to the third level, which is individual intervention. Can you click on the arrow? All right, remembering this chart and that some 20% of those suffering from PTSD back in '94 are still suffering today. Go back, please. There is certainly a justification for investing in the most efficient treatment for PTSD, which is still unequivocally individualized psychotherapy, trauma-directed psychotherapy, and on the one-to-one level. There is no replacement for that in the psychological literature today. And I just want to mention, I want to mention a quite impressive article that was just a couple of years published, written together by the 6 or 7 authors who devised the leading empirically supported, empirically supported treatments for PTSD. They have to include, so whatever it is that you wish to adopt as an individualized treatment, it should include, as we've already discussed, psychoeducation, means of emotional regulation, imaginal exposure as a way of consolidating the memory and building a narrative, which essentially post-traumatic stress disorder is a disorder of the memory of the event that happened. So these elements are necessary. And next slide. And I just want to mention one, which is by far and away the most researched one-on-one individual intervention for PTSD. That's called prolonged exposure, developed by Professor Edna Faw. And to just a few words about it as an intervention, go on. Of course, it has all of the components that I mentioned before. Go on. Okay. Improvement in PTSD symptoms, 93% in this particular study, 93% improvement versus a wait list. The improvement in the wait list, of course, might reflect the spontaneous recovery. But why wait if you can alleviate suffering more quickly? And not to mention the improvement of 93% versus only 36%. Okay, and fine. I brought this slide particularly in the Rwandan context because this is showing the rate of improvement in PTSD after rape and childhood sexual abuse, both of which are traumatic events which people tend to wait for a very long time. And of course, by definition, childhood sexual abuse is a very long-standing trauma, just like the 26 years since the Rwandan genocide. So the rate of improvement is not a function of how quickly you can intervene. Even if we intervene 26 years or 30 years later, we can get improvement and show people that they don't have to suffer anymore.
2 minutes.
I'm done. One more slide. No, the other way. You're going backwards. One more. Okay, and just to finish what I was showing you about PE, prolonged exposure. This is a graph, this is a chart which shows the rate of relapse, which of course we're not interested, after successful completion of PE, which shows that 94% do not relapse into post-traumatic stress disorders or related symptoms, and which is certainly evidence for a empirically supported treatment. Thank you very much.